That what we see, for example, or what I see in Geneva is very different from what I operate in Aswan in Egypt. So again, we have a lot to learn, and the nice thing about this session is to show us the exciting opportunities to learn from each other and to research things together. There are so many questions, and every time we answer a question, it seems to open other questions for us. This is actually the beauty of science. So I still think we have another 10 minutes. So if you have any questions for the speakers, I think we will all be happy to answer or to deliberate. Any questions? Parul, do you have any questions for the speakers?
Be an ideal candidate for an iWatch for you?
What would be the ideal case for an iWatch?
Candidate for an iWatch for you.
I give a talk on tubes, and I'll give it tomorrow morning at 9, okay? And there is what I call the Sharawi cookbook for tubes, about which one to use where. And I will tell you that I more or less have a specific indication for all the tubes that are available, except the iWatch. I don't really know at this point of time where personally I will put the iWatch in my armamentarium. I've used it and I still use it, but I did not discover a specific niche where I think it is superior to everything else. But this maybe question should go to Umnaya. Umnaya, she is very versatile with different tubes, and she's a very good surgeon. So what would be the ideal indication for an iWatch?
Indication for the iWatch, because still I cannot say also the indication exactly for iWatch, but I will avoid putting the iWatch in patient who has silicone oil, because already I blocked it twice with the viscoelastic.
So this is the contraindication for an iWatch.
So I mean, So I mean, still I cannot say what's the indication. I did only 5 patients. The 2 patients who worked well, surprisingly, uveitic patients. One of them still inflamed on a lot of oral steroids and immunosuppressor, and so far he's working very well while the eye was inflamed. The other patient, old patient with uveitic glaucoma, also worked well. So, even me, I try to, because I'm putting Paul, I'm putting also not too much Pervelt, but Ahmed Valve and Paul and iWatch a little bit. So, I will avoid maybe silicone oil, but I don't know yet.
I agree. The other contraindication, in my opinion, for an iWatch would be bad conjunctivas. If you have a very thin conjunctiva, you will struggle and struggle and struggle to close. Yeah. Because it's really the iWatch portion of the device is so bulky and big that it is not easy to cover it, and erosions would be catastrophic. I used to implant it under a flap. So I do a flap and then I do a deep sclerectomy dissection, put the iWatch and close with the same flap. But that will cover the tube, but will not help you if the conjunctiva is bad. Tubes are not easy with bad conjunctivas anyhow. Yes, Basil. Please. Why don't you come up and you can speak from here, if we can.
Tomorrow morning, inshallah, I have opportunity to talk again about iWatch, and I will try to say when it's better to use iWatch, and if it's preferable about Ahmed Valve or Multino. So do you prefer to keep this till tomorrow?
No, I think you should say now.
Okay. Indeed, iWatch a little bit take more time in the surgery and need a special care post-op to open and close the valve upon the pressure, especially in the few 6 weeks till about 2 months. After that, as Dr. Tariq mentioned, the pressure control will be upon the posterior blib around the blade. That's which will control the pressure for the next period. So just in cases when I need a good control for the pressure and to avoid hypotony as much as I can, then I will go for iWatch. Example for vitrectomized eyes, high myopes, ophthalmos cases in adults when they are more than 20 or 30 years and they need surgery in this case. Otherwise, I think our experience with Ahmed Valve and Molteno will be preferable than iWatch. Thanks.
Well, it's obvious that in lack of clear studies, randomized studies comparing one tube to the other, what will guide us at this point of time is surgeons' preference. Also other things like economic factors, which expenses is very important, ease of use and accessibility. Not all of those devices are available everywhere. A lot of them actually are not even available in the States because they are not FDA approved. Other questions? Yes, Dr. Ali. So it's a question to Dr. Zainab about micropulse.
Excuse me, I cannot. It depends on the laser settings applied. As I mentioned here, in the articles in this review, there was a broad spectrum in the laser settings. I mean, in most of the studies, the laser settings were very much variable. So in a recent study I mentioned there, they used higher than usual settings, and they said that there's not a drastic decline at first year. So I think it may indicate that laser settings need to be defined in this procedure. So I can tell us. For what kind of patients? Yes. The better parameters are, in fact, actually in micropulse, I don't have any much experience. I use continuous wave still. In Turkey, in Istanbul, we have only 2 micropulse devices in 2 institutions. So I don't have any experience on micropulse right now. And so I think it depends on the glaucoma stage, I think. The glaucoma stage, because it preferably 360 degrees, they say that we should apply, but some people apply 180 degrees. So they have satisfying results. So it is today hard to say constant parameter, I think.
Maybe it's this, anyone have this better experience, because I try all the parameter in more than 100 cases. Always is different. You didn't have the first 2-4 months very good result, and after that dramatically the effect is decrease. If you calculated, I calculate my result over 1-2 years is 30%, but plus medication. And for that, my message is not a good indication for early cases. For any early cases, is not a good indication. I try all parameter I use only for advanced cases. I didn't use for any primary or for mild to moderate glaucoma, only for the end stage. But with the end stage glaucoma, always I need another procedure later. This is the problem. If anyone has better experience or another parameter to advise, because 360 degrees, I try with the power, with the lower the parameter, as only said, this is 80 to 90 seconds. After that, I increase to 180 seconds. On 200, also 40 seconds. Also, I decrease, only receive better result in the few months. And after that, I lost the effect. The same with the lower time on lower power. what anyone has more experience?
I want to ask how many sessions do you apply? I mean, at first session, it may not be as effective. Okay, 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 okay.
Dr. Ali, I have a micropulse device for the last couple of years in Geneva, and I worked with Paul Chu in Singapore on the early studies. But to be very honest with you, I more or less don't do it in Geneva. Most of my cases, I go back to classical diode. I'm not a big fan. I'm a big fan of Paul, but I'm not a big fan of the MP.
I also mostly apply continuous wave, classical, and we have one study showing that in eyes with good visual acuity, we also had satisfying results. I mean, we did not spare it for only refractory glaucoma eyes with low vision. So it may be applicable, I don't know, what do you think, Dr. Sharavi? It may be applicable to the eyes with good visual acuity also?
I think what you're saying makes perfect sense. We are always getting bad results with cyclophotocoagulation, whatever we're doing, because they are very advanced cases. Once we are comfortable about the safety of a device to the extent that we can start treating patients with short-term sessions or titrable sessions of cyclodestruction, maybe then we will get decent results. But having said so, I think we had a meeting, and Ziad Khouer was with us in Switzerland a couple of months ago. And Ziad is one of the people who published a lot about micropulse. But he still himself is not doing that as a primary procedure and not offering it to patients with excellent vision. So there's still a reluctance to embark on cyclophotocoagulation even in the hands of experts.
Okay, now we are closing the session, and I would like to invite the speakers on the stage, please. The speakers, please, for a picture.